All right, wonderful. Thank you so much, Roxana, for an excellent presentation. Once again, just to remind everyone of the panel we have, Dr. Meran will be co-moderating the session together with panelists, Dr. Benita Shah, Mitul Patel, and Dimitri Feldman. And we have excellent talks from Dr. Bangalore, Dr. Naveen Kapoor, Hari Naidu, Arnold Sito, Ethan Korngold, Tim Henry, and Santiago Garcia. So without further ado, we'll go on to the discussion. And maybe I can kick it off, Roxana. Obviously, you've done a phenomenal work with Twilight. That's truly a paradigm change. Similar to drug-eluting stents in many ways in doing PCI. Have you seen much adoption of this approach? Are people using this, or are people still in the learning curve?
Yeah, so thank you. Thank you for giving me the opportunity. Congratulations on CVI Innovations Summit virtual. I wish we were all together in Colorado as usual, and look forward to doing that next year. This is a beautiful program and a fantastic panel this morning. So, you know, when you asked me to talk about PCI pharmacology, I chose P2Y12 monotherapy because I think it's sort of like the hottest topic right now, a new paradigm for us to kind of consider, especially in patients in whom we really want to prolong the duration of P2Y12 inhibition as long as possible. And I think that it could be done without the bleeding complications, or at least less bleeding, if you actually stop aspirin instead of stopping the P2Y12 inhibitor. We felt that it was important, especially in complex patients, complex lesions. We showed that in Twilight. And then, of course, in patients with acute coronary syndromes, we just saw the TICO study, which I just covered as well, showing very, very similar effects. So I do think that in certain patients, it could be a way to go. I'm not saying that that's the thing to do for everyone, and I would be a little bit concerned about stopping, you know, in a complex setting, in a high bleeding risk patient, in whom we put in a few stents in a bifurcation lesion and put the patient on clopidogrel to kind of stop the aspirin there and give the patient clopidogrel monotherapy if we haven't tested that patient. And that's why I talked a little bit about genetic testing as well. So it would be actually nice to hear. I personally have adopted this in my practice, and it's been so far so good. It's not that long. We only presented the results of the Twilight trial in September of last year. So it really usually takes a couple of years before you adopt such a thing. We'll see what guidelines we'll do. Those are now in conversation. We'll hear from them at some time in 2021. And all of the evidence is being put forth. So it would be really interesting to hear what everyone else thinks. So Mitul Patel, Benita, Tim Henry was on so it's not fair because Tim was on the Twilight steering and executive committee, but Dimitri Feldman, all of you guys, you're all practicing. What do you think about the P2Y12 monotherapy? Let's start with Dimitri Feldman. Are you incorporating that into your practice? Do you think it's the way to go? Did you all see the meta-analysis by Michelle O'Donoghue that actually put all of the data together, and she showed a reduction in bleeding without any ischemic harm? Dimitri?
Thanks, Roxana, and thanks, Manas, for having us all over. I think, you know, number one, Twilight is a tremendous contribution to our understanding of periprocedural pharmacotherapy. And I think your analysis, looking at the complex patients, looking at the diabetic patient, highlights that even in very high-risk patients, it is an important and safe strategy. So yes, we have incorporated it. But I think logistically speaking, I think there are challenges how to do it well in a real world practice. And I think as interventionalists, we do the PCI, complex PCI, we make a recommendation what antiplatelet therapy patients should be on immediately after. And then the discussion is what should happen 3 months, 6 months, and 12 months. But in clinical practice, it's often the general cardiologist that will follow those patients. So I think what is tremendously important is to keep that line of communication between the interventionalist, if that's not who the primary person following the patient is, and the general cardiologist, so that at 3 months, 6 months, and 12 months, there's a continuous reevaluation of the ischemic and bleeding benefit, at which point you can reevaluate that decision whether ticagrelor monotherapy is the right thing to go forward as planned, or whether some switches need to be made.
Anita, how do you see this?
Can you unmute yourself? Sorry, Benita, you're still muted.
I completely agree with Dimitri in the sense that having that conversation with the cardiologist who will be taking care of the patient is so incredibly important, because we can't, the worst thing that we could do, in my opinion, is that we stop the antiplatelets when something bad happens, you know, if they're bleeding or if they're about to go for surgery, that's emergent. And in that setting, I get very worried. You know, I worry about the inflammatory response in that setting. I worry about what's happening with their platelets versus a patient who has been able to discontinue in a more elective setting. It just, to me, that seems more appropriate. But also, you know, having the referring physician look at the films with you and sort of go through, you know, which would be an appropriate patient to consider an elective discontinuation versus a patient who probably should be on more prolonged therapy is important as well.
The other thing that happens, I think, that we have to deal with in terms of culture is that, you know, these patients are ours for a short time, and then they go out into the community with their cardiologist and their primary physician for many years, and things happen, such as, for example, they need a colonoscopy or an EGD or some surgery, and we're so used to stopping the alternative to aspirin. So what do you do in those situations when surgeons and whatnot are not familiar with the bleeding risk to continue these medications for those procedures where we have continued them for aspirin and kind of gotten over that learning curve? Is it possible? Or are we going to, I worry about some of the downstream inadvertent problems if you stop it. They stop it reflexively, and now they're not on anything for their procedure.
No, it's a very, very good good question. We're evaluating that analysis within Twilight because, as you can imagine, monotherapy with ticagrelor, some of those patients ended up having needs for procedures. So we're going to present that at TCT. It's a very, very important point, and I think it just kind of talks so much about how important it is for us as interventionalists to be close to the treatment team and to be close with that patient, to talk to them about all of this. The patients have also a different feel about aspirin. They feel like that's an old drug. It's been around forever. Saves you from heart attacks. The secondary prevention data is strong. There's some cancer data that is strong. So it's very, difficult. I think this, and this is not for everyone. In my mind, I think Twilight really does tell you who is the best patient for this. Tim, you wanna pitch in?
Yeah, I do, because I think it's a really important study. And listen to what we're listening to is we know the data, and the problem is medicine in United States is still too individualized, right? It's based on this primary care, this primary cardiologist, and this really shows you why having standardized protocols and systems in place allow better care. And I agree with everybody in the panel. I mean, I've obviously tried to implement this, and clearly you can do it well in individualized, well-educated patients who don't let the system goof them up. But things that happen are you stop the aspirin, they've had no problems, you stop the aspirin, and they're on monotherapy, and then someone changes them over to clopidogrel, right? Well, I don't think you certainly can extrapolate to clopidogrel alone. And or they have trouble with their pharmacy with ticagrelor, or that's the problem, is the system goofs it up. And so what I think, and this will happen, is that we'll try to get standardized protocols in place so that it automatically happens, that's what you put in your recommendation to start with, and it happens. But the data is really good, and I think strong, and now becoming more consistent. It's just we have to find systems and put systems in place to make to apply best care.
Naveen,
so aspirin is
for
over
you?
the counter, and
Yeah.
Linta is BID and insurance issues, so pharmacies may stop it, and then before you know it, the compliance rate is much lower
Right.
than the clinical trial, and then
Well, yeah, no, there's no question. And I think it just talks about how important it is for us to kind of think about this. The idea is that we've got to get the best outcomes for our patients. And what we saw in Twilight is that, and I think especially for acute coronary syndrome patients, we really want to keep giving them the potent agent as long as possible. And I think we can reduce bleeding and give it to them as long as possible if we stop the aspirin. I think that's where we're going. Naveen, last comment before we go to our, I want to make sure that I stay in time. Manos, please keep me in time. But I want to go to Shripal very, very soon. But Naveen, you do a lot of complex procedures. What do you think about, how often do you put your patients on ticagrelor, even if they're not ACS? And have you incorporated the ticagrelor monotherapy in your practice?
Yeah, it's a great question. I think, all the comments have been terrific. And in our practice, I mean, we certainly have seen a significant uptick in the use of ticagrelor for the non-ACS population. Certainly for the ACS population, this has now become a mandate. For us, it's also about systems of care. All of our STEMIs are actually now in the community hospitals, and getting those community hospitals up to par with the guidelines has been really our focus over the past 12 months to make sure that patients are getting optimal pharmacotherapy. I think the point you bring up, though, about the bleeding is really important because, as you said, a lot of these patients come in, they get multiple interventions done at the same time, especially if they're critically ill. And this area of focus hasn't really come to the front line in terms of antiplatelet therapy for example, some of those STEMI shock patients. And I think that's another area that this will start to go into is the acute setting as well as the follow-up for these patients.
Well, thank you so much, Naveen. And this is great. I mean, we have such a great panel. We can talk about this for hours, especially me, but